Hi, I'm Catherine Ayers-Wickenhauser, Director of Communications at Direct Trust, and I'm so excited today to be joined by University of Pittsburgh Medical Center, who has been named one of our interoperability heroes. So UPMC, welcome. It's so exciting to be with this great crew today, and I'm really excited to learn more about you all and your approach to interoperability. So Dr. Faterik, if we could start with you, can you tell us more about UPMC?
Catherine, we are so excited to be here, and it's such an honor to be selected for this award. I wanted to share with you that UPMC has been a very early adopter of electronic health record technology. We've been a pioneer in interoperability and health information exchange. Maybe just a few words about us, and this goes probably beyond 30 years, but we have grown from a single institution into a $21 billion integrated finance and delivery system. We are closely associated with the University of Pittsburgh, and our health system encompasses 40 academic, community, and specialty hospitals with about 8,500 licensed beds, and we have more than 800 outpatient sites. Our health plan, UPMC Health Plan, is Western Pennsylvania's largest medical insurer. I think it's also important to point out that we have about 6,000 affiliated physicians and nearly 4,900 employed. Annually, we see probably about 1.1 million emergency department visits, about 38,000 hospitalizations. Just a few more words about our technology landscape. We have started our journey with electronic health records several decades ago, and we have a best-of-breed ecosystem with multiple applications tied together with a single sign-on and patient context management. Most of our hospitals use Cerner Millennium, and we are client-hosted. Our outpatient sites have EpiCare, and our cancer centers use ARIA. We have implemented Allscripts DB Motion as our interoperability solution, and we also use a dedicated health information services provider, Security Solutions, and their notification engine. On the interoperability side, we have been a founding member of Western Pennsylvania's Clinical Connect Health Information Exchange, and we also participate in Commonwealth, Care Everywhere, and Care Equality frameworks.
Amazing. It's incredible to hear about how broad UPMC is, the different, how much area you all cover, and also hearing some of your commitment to interoperability in there as well. So I would love to learn more about that. Maybe Diane, could you tell us more about UPMC's approach to interoperability?
Yeah, sure, Catherine. So yeah, as interoperability is really important here at UPMC. So what it does for us is it ensures that our patient data is really shared accurately, to our providers, and whether those providers are internal or external to our organization, as our reach gets further and further. But as Dr. Faterik mentioned, we are that best of breed, approach, and have been that way. And interoperability has really shown to us efficiencies through communications across all of those EHR platforms that he mentioned. It also helps communication between referring doctors and our specialist. But really, having that patient's longitudinal record at the point of care is so vital for us because it gives the providers the information that they need to more accurately diagnose the patient and prescribe their care. But it also, we have found, helps to decrease those unnecessary tests, which are not good for the patient and also can have additional cost involved. And I guess maybe even in the more recent years, interoperability has really helped us meet our regulatory requirements. So from what was meaningful use and now promoting interoperability and the 21st Century Cures Act and information blocking, which keeps all of us very busy, it's really helped us meet those requirements. So today we're really focused on, expanding the ease of access to all of this information, especially for our patients. And also providers, and it does help our patients to manage their own care. So when I think about it overall, interoperability is key to us because it really continues to help us deliver that safe quality care to our patients And it really helps to meet the needs of everybody, our providers, patients, and our families.
Absolutely. And, I love that you highlighted how important this is to patients and to providers, and getting that timely and accurate sharing of health information. And, back to something that Dr. Paterick said about being involved with a HIS and Commonwealth and care quality. I'm curious, maybe Sandy, could you tell us a little bit more about how mature UPMC's interoperability approach is?
Sure. I would say in 20, I would call our program pretty mature. But of course, we're always growing and changing as the technologies change. UPMC, we first engaged in interoperability about 25 years ago, and we started our initiative with aggregating data across our integrated delivery and financial system. And then over time, we expanded to connecting with the community outside of UPMC. When we first started, our integration began primarily as HL7 interfaces and have expanded today to include a variety of query-based exchanges, including local, state, and national health information exchanges. Our most recent technologies include direct secure messaging and real-time patient event notifications, which leverage direct as its communication method. Also, over the years, we have developed a vocabulary management program, which helps to harmonize the data across the systems and to ensure the information is meaningful and actionable where needed.
Thank you for sharing that. And it sounds like it's been quite a journey. I mean, 25 years is awesome. And I love the Interop letters in the background too. So thank you for telling us more about that. And hearing about UPMC being such a large institution and knowing that care transitions are particularly critical to the patient experience, could you describe maybe how the organization handles these care transitions, Ray?
Yeah, I can certainly do that. And thanks, Catherine. Community provider services, it's a small component of UPMC. As Dr. Paterick mentioned, UPMC has grown incredibly over the last 20 years, and most of the folks on this call have been around for every bit of it. So the Community Provider Services Division is a large portfolio of pre- and post-acute provider organizations covering western and central portions of Pennsylvania, or all of western and central Pennsylvania. These programs and providers include home care and hospice, private duty, community services, skilled nursing, assisted living, independent living, institutional pharmacy, retail pharmacies, infusion pharmacies, specialty pharmacies, a community life program, inpatient and outpatient rehabilitation, advanced illness care, remote patient monitoring, in-home urgent care, which is a new program, and a DME and oxygen partnership as well. Our UPMC Innovative Home Care Solutions Group is a new company that's formed in the last couple of years, and it was launched in conjunction with our health plan. And it's designed to implement innovative and accountable post-acute and community-based programs that improve patient care, enhance patient outcomes, and lower the total cost of care. The CPS Community Provider Services IT organization, which I'm part of, and several of the folks on the call, is a small group of highly experienced IT professionals. Most of us have been around for over 20 years and have worked in this space extensively, so have really good background. We collectively provide focused and dedicated IT support for all of the organizations that I mentioned above, but we also function as a component of the larger IT organization, which Sandy and Diane and others are part of. The care transitions and referral activities fall under the Innovative Home Care Solutions scope of services. These services include a large group of nurses. Tracy will talk more about this, but we call them nurse liaisons or post-acute liaisons. They're deployed across the majority of the hospitals that Dr. Paterick mentioned, and they work in direct support of care management in those facilities to facilitate those referrals for home care, hospice, infusion, DME, oxygen, community services, to name a few. We also support a call center. It's called the HRRC, or the Home Care Referral and Resource Center. That group was created under the Innovative Home Care Solutions company, and they support the ambulatory referral process. And that group specifically was one of the benefactors of the project we'll talk about today. At the heart of care transitions for community provider services is an application we call Care Transitions Manager. It's an application that was developed internally, designed and developed internally through several iterations, and it is used in most post-acute care transition settings. It's highly integrated with our acute, ambulatory, and post-acute EMRs, and it is a foundational component for this project. Lisa, Tracy, Tamika, others will talk much more about the details behind that, but thank you.
Thank you, Ray. Tracy, can you tell us more about the Care Transitions Manager application, especially since it was developed internally?
Yes, as Ray had mentioned, Care Transitions Manager is an internally developed application, and it was built approximately 10 years ago. Lisa's going to speak later, and she was the key developer and her support staff in building this application. It is used by our UPMC-owned hospitals and physician offices for both internal and external referrals. So we do place both internal and external referrals, which gives us an edge, and we'll be talking about that later. As Ray had mentioned, it's used by many different departments. Our PALs, our post-acute care liaisons in the hospital. We also have the HRC team that Ray mentioned, and we do have direct intake from numerous different business units. So they do get referrals from non-UPMC referral sources and use this application as well. We collaborated, or wanted to collaborate with our physician division for a solution for ordering home care for many years, but we initially couldn't get much traction until some of the meaningful use MIPS regulations came into play. And that kind of gave us a starting ground or a reason to look at a solution. When, as Ray had mentioned, we had some strong physician leadership in Dr. Ferrarello. He was our champion, and without him, I don't think this project would have gotten where it was. So I really appreciate his support. He has since retired, but he was key. And he always referred to this application as the easy button. He wanted one way to place orders for home health, whether they were coming in or not. And he often, like I said, referred to it as the easy button. So our goal was to create something easy enough for the physician practices to use. When we looked at on moving to a solution, we decided we were going to pilot it. And we piloted it with 3 different physician practices. And we did that back in 2019. November of 2019 was our go live. And we also decided we were going to survey physicians prior, during, and after the pilot to make sure that we met the goals that we had all established. We had numerous teams within UPMC involved in this initiative, and obviously some have spoken so far during this call, but we could not have been successful without numerous teams involved. And thankfully at UPMC, we do have a great support system, even though we all kind of work in our own individual supports for post-acute versus hospital versus physicians. As a group, we work really well together and cross those silos when needed. We have numerous integration points within CTM, and today we're going to specifically talk about our integration with the Epicare application, which is used by our UPMC physician practices. So that's going to be our focus today. Thank you, Catherine.
Thank you, Tracy. And it's incredible to hear about the team approach too. I think that's so important for interoperability. And I love that easy button concept. Certainly, I think that resonates with many people. We want it to be as easy as possible. So thinking about referrals specifically, historically we hear that referrals take a lot of time. So especially I think too, when they're to post-acute settings. Can you tell me more, Lisa, about why UPMC turned to interoperability to decrease clinical burden so providers could focus more on their patients?
Sure. Thank you, Catherine. Well, one thing that was brought to our attention that it was a very onerous and cumbersome process to do referral management, to set up these referrals for our patients. on average, it took 97 minutes to set up home care for a patient, which you can imagine if you have X number of patients times 97 minutes, you're spending an awful lot of time on the phone trying to arrange care. And it was the time was even compounded by the fact that, worldwide we have a nursing shortage. So there were zip codes that maybe some agencies couldn't cover. They call those curtailments. And so simply the physician offices may have to call 2 or 3 agencies to place a single patient and add the number of patients that they might need to set up care for on any given day. It was just taking an extraordinary amount of time. So that was the problem that was brought to us. There was a lot of faxing of documents back and forth, a lot of phone calls back and forth. So if you can envision, it was just like a web of communications going back and forth. And so there was a lot of time spent, and our physician practices needed our help. So they came to their IT partners and said, what can you do to help us?
That's great. And I love looking at it from a partnership approach. And so looking at moving forward then with interoperability, were there specific goals of the project? Tracy, do you want to tell us maybe more about that?
Thank you, Catherine. Yes, we had specific goals. We had actually goals for a couple of different areas. So from a post-acute, from our home care agency's perspective, they had some goals that they wanted to meet. They wanted to increase, obviously, overall referrals to their home care agency. But if they couldn't come to our home care agency, they wanted to be able to determine what the leakage was. How many are going out of system and why were they going out of system? From a physician practice, as I mentioned, Dr. Farabello always used the easy button. He wanted one process for all home health referrals, whether they were coming internal or going external. So it was key to be able to use one direct message mailbox so that all the referrals would come into one centralized intake area and they would process it whether they went in or out. They wanted to decrease the amount of time, obviously, that it was taking to set up home care for patients and the amount of time the physician practice was spending on the phone calling all of the different agencies if we could not place them with our internal agency. And of course, those regulatory requirements we were trying to meet. So those were the main goals of the project and why we were engaged.
Thank you, Tracy. And thinking back to Care Transitions Manager, are there specific components or things that you'd like to outline, Lisa, maybe about how Care Transitions Manager works?
Sure. First off, I want to refer back to what Ray said about setting up this HRRC group, basically a central intake group that would take the burden off of our physician offices and trying to arrange these referrals. They were specialists. These people who worked in this office are specialists. They understand insurance idiosyncrasies. They understand curtailments. And this was their area of specialty. And we wanted to take the burden off of the physicians. So what we did, we wanted the physicians to be able to work in their EMR system that they're in every day. We didn't want to have to burden them any further to go to some other application. So we said, okay, you can just place your order in your system, Epicare, that you're in every day. You place the order and we'll take it from there. And the way that we did that was we set up, as Tracy alluded to, we set up a single direct address. So once that order was placed in Epicare, a CCD was generated from Epicare and directly sent via direct messaging to our single mailbox. And that single mailbox, then we created a process to monitor that mailbox and pull out the messages from the mailbox and take those attachments that were CCDs and process that attachment and pick apart the pieces of information that we were interested in, all the clinical rich data, the demographic data, and so forth. So we were able then to take that information and create a referral for our central intake staff to work. Now, not every piece of information that we really wanted was in that CCD. So we did think about supplementing, and we were able to supplement that data that came over in the CCD or that was missing from the CCD, so to speak. So what we did is we worked with our interoperability partners within UPMC, and we were able to create a web API that allowed us to even pull additional information from our EMR system. So by the time the referral got in the hands of our specialists, our central intake group, it was already very data rich. It was full of demographic information and clinical information. And so there wasn't a lot of data entry responsibilities for our central intake staff, which was great. So our central intake staff then would work the referral within our CTM application, which was their workflow tool. And from within that application, they could then set up care, fax these clinical documents that were generated out of CTM to agencies directly from within the tool. And if the referral stayed within UPMC, we had direct interfaces into our home care applications. So there was no faxing needed there. And then once the referral was accepted by the agency, we were able to close the loop and communicate back to our physician practices via technology we developed internally called UPMC Notify, in addition to our vendor partners, our HIS providers helped us with some of these pieces and parts as well. And we were able to then communicate back and send a message back into their EMR, their Epic Care system, that let them know the agency that we placed the patient with, the phone number, start of care, and even some special instructions went back to the physicians. So it really rounded out the whole continuity of care and the communication loop.
And I think there are so many great tips and everything you just outlined, and you highlighted so many different components of information sharing. I think, what resonated with me, just describing how this works and some of the components, that drive to get the right information in the right hands at the right time, closing the referral loop. And something else you said stuck out to me. So the single direct address, I think from the direct trust side, we see the organizations who excel with direct secure messaging and interoperability in general take advantage of the opportunity to have an organizational or departmental address. And so I think that's what we've seen with UPMC and how UPMC has excelled doing that as well. So I think that's a great tip for the listeners today, is to see if that's possible in their own systems. And to that same effect, I'm curious, maybe, throughout this project, and obviously you all have a tremendous amount of experience, what challenges did you encounter and what lessons learned were there? So Tracy, maybe if we could start with you, if you could describe some of those, that might be helpful to the people listening in today.
Yeah, I'll be glad to share some of the challenges that we have, and I'll be also letting Tamika speak, because she was very instrumental in getting some of these issues resolved, and same with Sandy. But one of the things is we're a large organization, as Ray and Dr. Fatirik mentioned. And so we had 1,300 unique physicians, over 579 practices ordering home care through this process. So obviously education was going to be key in making sure that they understood how they were to place the order, etc. With that many physicians, obviously we had physician setup that needed to occur around missing direct addresses, etc. So I'll let Tamika speak to how we handled physician setup.
Yeah, physician setup is basically an automated process. And then by troubleshooting the missing CCDs that Tracy's team would hand off to us, we were able to streamline that automated process to eliminate some of those error rates. So just by working together as a team, they would kick it off to us and we were able to streamline it and reduce some of those error rates that we were seeing with the automated process. So Tracy, I'll send it back to you.
The other thing that Tamika and her team were able to help out is the fact that the patients were able to choose to opt out of data sharing, which that equated from our perspective of not receiving a CCD. And we're working together as a team to decide or determine how we can know that up front, because even though a patient might choose to opt out, that doesn't mean that that care doesn't need to be provided. And I don't know, Tamika, if you want to talk to some of the opportunities there that we're working on so that we have access to seeing that data.
Yeah, so this is just another another troubleshooting area that we handle. Currently, CPS does not have the ability to access the patient data sharing consent status in the EMR. So we add that to our troubleshooting our troubleshooting, and then while working on them to get access to get that information. So that's in process so that they will be able to get that consent sharing without reaching out to us. But currently, that's another troubleshooting area for us.
So a couple of other issues that we noticed, and some of it is just learning how the EMR handles the processing of CCDs. But the other thing we noticed is that if physicians often order medications as standing orders or future orders, and what we noticed is that impacted the CCD if they were ordering home care. So instead of getting the order the day they received it, it thought it was a future order, would not send us the CCD until that future date. And same with standing orders, we would continue to get a home care order if they placed it as standing. So we had to look at some of the configurations within the system and how it handled normal orders and how we wanted it to handle these CCDs. So we did have to work with the Epic team on future and standing orders. We also needed to determine how to handle issues around, again, we're a large organization, so we see patients in New York, and New York State has a regulation around data sharing, and we're not allowed to receive a summary of care information on any patient that comes from the state of New York. So we needed to decide how we were going to handle the New York state issue, how we were going to handle multiple summaries of care for a patient who has an encounter in Epic, one encounter, but yet home care is ordered 3 or 4 times during that encounter. And that caused us to receive numerous CCDs. And on our side, how were we going to handle processing those numerous CCDs? We had to look at that as well. We also had some challenges around modified orders. In Epic, you can edit an order once it's been created. And we needed to just determine how we were going to handle those modified orders. And we're still working through some of that. There's a way to re-trigger, and we're hoping that that might help with some modifications. The other thing, like Lisa had mentioned, is the clinical rich data. Obviously, what came in the CCD and what was reality and what our home care agency needed and wanted in order to appropriately take care of the patient wasn't the same. And so we had to work on a web API so that we could pull out additional clinical data. So that was a challenge, making sure we can get all that data that we needed. And then one of the things that we decided up front to do and has been very beneficial from an organizational standpoint was reconciling. We decided that we wanted to make sure that we were receiving all the CCDs that we expected to receive. And so we decided to create a report, and we had a report before we moved into it, but we decided we were going to take this report and we're going to reconcile it against the CCDs we received on a daily basis. And we actually do this twice a day. And if we were missing CCDs, then we knew that we would have to notify our HRC team so that they could create those referrals without maybe the actual CCD, but at least we weren't missing any patients. So those are some of the challenges we had.
Thank you, Tracy. And I think, outlining those for those listening is so helpful because often, we talk about the success. We've currently heard a lot from you about the success that you're having, but certainly helping anticipate where some of those challenges might be and some of the lessons learned is critical for helping other organizations too on their interoperability journey. And thinking about perhaps the outcomes that you all have seen, maybe can you highlight those a little bit more? So what successes have you seen? What have been the outcomes of this project overall?
When we were looking at the efficiencies, and I know Lisa had mentioned this, we wanted to, of course, decrease time. So when I go through these efficiencies, I'm going to kind of categorize between the benefits at the physician practice, our HRC, our central intake department, and our agencies, our home health agency. So first up, from a physician practice perspective, again, Lisa had mentioned the time it took, and I believe she gave some numbers, but we went from 97 minutes down to 11 minutes. So obviously that was a huge time savings. We also saw a 57% reduction in the number of steps it took for our physician practice to do the referral. We also delegated the referrals to a central intake department, which Ray had mentioned, our HRC. And so this department was familiar with clinical criteria in order to get home health. For instance, we were getting physician referrals from physician's office where only they needed a home health aide. Well, that doesn't qualify you for home health. So having this centralized intake area familiar with those clinical criteria and regulations helped us make sure we were receiving the patients appropriately at the right time in the right setting. They were also familiar with the zip codes and our curtailment and our insurance contractual agreements, and again with curtailment, so we knew who we could see and could not see. They also entered communication notes, so our physicians were able to see in Epic here, as Lisa had mentioned, where the patient was going to be placed at, what the estimated start of cure date was, and a phone number so they could reach back out if needed. And then the third thing the final thing from a physician practice was around the face-to-face. We're able to get the face-to-face questions as part of the order. And so from that perspective, we have assigned face-to-face up front now when we're seeing our patients from a physician practice. So the only thing that we had to worry about is PAs, because unfortunately in the state of Pennsylvania, PAs cannot sign the face-to-face. So those are the only ones that we might have to go back for co-signature. So the face-to-face piece was huge from a physician practice, because of course those can be burdensome for them to have to fill out after the fact. So next up is the central intake, the HRC team, and what some of the benefits that they had. And one of the main things is it's no touch. All that clinical data, for the most part, we received up front when the physician office put that referral in, and we're taking that data and pushing it downstream. So from an HRC perspective, they get a referral that has a lot of clinical and demographic information already pre-populated. So it reduced the need to create patients from scratch. It reduced the need to fill out manually a lot of the demographic and clinical information, because we were able to pull it forward. That also then helped with making sure we didn't have patients' name incorrectly spelled, wrong date of birth, etc., in our downstream application. And then being able to reach back in and get that additional clinical information that Lisa mentioned. I just think that that really sets us apart from our competitors. Anyone can get a CCD, but what makes us unique is not only do we get a CCD, but we get that clinical rich data that our home care agencies said that they needed in order to appropriately take care of the patients. And I do know that others are getting some of that data in PDFs and other mechanisms. What's unique is because we get it in discrete data fields, we can also report and look at clinical indicators to make decisions in the future on our patients. And it's not just one big clog of data in a PDF file that you can't discern anything from. And then lastly, our home health agencies and what benefits that they received. Some of the benefits from them were related to the volumes. So when I look at 2021, we processed roughly 88,000 referrals, home health referrals, through our application. And of those, of those 88,000, 22,000 were from UPMC-owned physician practices using Epic Care. So that's about 25% of our referral volume, our referral source volume. What we did see is we saw about an increase of about 11 referrals a day. So it was about 4,200 a year between 2020 and 2021. So we did see an increase. Obviously, now we can determine where our leakage is, and we can then take that leakage and say, where is it by zip code, by insurance, by physician practice. So we can go back to the practices and ask them, if they're not referring to us, why, what can we do different? But from a business perspective, we can go now and look and say, okay, do we need to add and cover certain zip codes because we might not be covering and that's why we're leaking? Or do we need to have contracts with other insurance companies in certain regions so that we can take those patients? So it gives us some business logic that we didn't have before. Obviously, we have a clinical rich referral that is appropriate. We don't have to worry about getting referrals that don't meet home care status. So that's a benefit as well. Getting that in a discrete field allows us to pre-populate all that information in our downstream application, which we also support. So it's really a no-touch interface. Our home care agency receives that data without having someone have to data enter again. And then being able to make changes to the face-to-face requirements is also a big win. So if from a regulatory perspective, tomorrow they decide face-to-face is going to require X, Y, Z, we can make some programming changes in our application and allow the centralized folks to fill out that face-to-face and send it outbound. So we've been able to make those changes without a lot of manipulation in multiple applications. So those are, I know I went through quite a lot there, Catherine, but those are some of the benefits we saw.
That's okay, Tracy. And it's amazing to hear all of the efficiencies that you all have gained and the impacts that it's had to not only provider burden and lessening provider burden, but also thinking about the patients in these situations and trying to expedite getting their care, and how impactful it is to have a clinically rich data set to pull from. And I love that you hit on the differences between the PDF and the CCDA, and just those considerations when you're doing exchange, because the ability to save time and impact business processes by pulling that data out that's already been recorded is huge. So thank you for highlighting that, because I think that's certainly a lesson that others embarking on their interoperability journey or advancing their interoperability journey can learn from too. And listening to just the breadth of experience that you all have and the success that you've had, I can't help but think of where you're going to go next, because you've accomplished so much already. So Diane, could you share with us maybe what are you thinking is next for UPMC's interoperability journey?
Yes, sure, Catherine. So, I mean, there's always work to do, right? Hopefully that we can expand on these projects that we've done and continue to close the loop on referrals, continuing to meet, regulatory requirements as well. But the one thing I take away from all of these projects too, as our listeners heard, these are collaborative projects and they really take time and innovation. And the one thing I learned is you just have to keep going. So from an interoperability perspective, just keep going, go down that road and don't look back.
I think that's great advice. And I guess in that vein too, I'm curious if others have advice, final thoughts, or words of wisdom that they would share with peers who are out in this space. So Ray, what about you? Anything that you'd like to add?
Yeah, I would. I mean, I do feel like we're just scratching the surface. I really do. This was a first great project, but there's so much more we can do, and we're already thinking about those things and talk about them frequently. I think that really strong physician, stakeholder, word of wisdom, involvement was just so key. Dr. Fiorillo was a champion, a friend, a supporter of post-acute. This really was an exercise in persistence, but it really did show that we can integrate well as a team and as a health system. So that's what I have.
Thanks, Ray. And yes, I'll think back to that easy button analogy for sure. So Mika, what about you? I know you offered some great lessons learned earlier in our conversation. Any final thoughts or words of wisdom that you'd like to impart?
I think Diane hit it. Just keep going. And I think the team approach is always best. I mean, collaboration is key. to anything where there's more teams than one involved. Just keeping an open mind and moving forward.
Great advice. Thank you for that. Always love the team approach to interoperability. And Tracy, you've outlined a lot for us today already, but curious, any final thoughts, words of wisdom from you?
I think that one of the biggest things that I did not initially anticipate and learn pretty quickly is around the need for physician and office manager training. Again, we have a large physician base, but I had thought from the get-go that they understood home health and what the requirements were around needing homebound status, et cetera. So one thing we learned is not only did we need to educate on how to place orders in Epicare for this, but also we had to spend time educating them on homebound status, what you could and could not order, et cetera. So make sure you put time aside for education. That was huge.
I think that's wonderful advice. As the whole interoperability and health IT industry matures, I think we're seeing education of providers and clinical teams is probably the #1 emerging opportunity and a place where we can truly make impact in advancing interoperability. So I love that you brought that up and planning for that education of teams. Sandy, I want to kick it to you now, back with your lovely Interop letters behind you to close us out. So any words of wisdom, final thoughts from you?
I think, everyone, we talked about collaboration and teamwork. And I think, through and through over the 20 plus years on interoperability and at UPMC, the one theme that always comes back is the partnership between IT and clinical. I mean, the best projects we've implemented with the most successful outcomes, I think it's always gone back to it's a partnership between IT and clinical. I think that's where our results come from.
Great final thoughts. And I think that's exemplified by the number of people on this call and just seeing the depth of your interoperability team and the commitment of UPMC to interoperability and really to taking care of your patients and providers too. So thank you all for being here today and for sharing your wealth of knowledge with the audience. I think this is going to be an incredible tool and source of inspiration for many in interoperability. And congratulations again too on your Interoperability Hero recognition. Thanks for sharing this conversation with us today. And to see more interoperability hero spotlights like this, check out directtrust.org/Interop Hero.